everyone, welcome to ResearchMD.com and the great presentation today. Let me introduce myself. My name is Pramil. Cheriyath. I'm a program director, internal medicine and transitional residency in the United States. I teach medical students and residents on a regular basis, and I'm also assistant professor of medicine, 2 large medical schools in the United States. Okay, so we've been doing series of lectures on anemia. We started with the microcytic anemia. We started with the macrocytic. Now we are in the hemolytic anemia, and today we got a very important topic. Okay, please make sure you review this thing again after the presentation, because there's a lot of information we're trying to cover on this huge whiteboard over here. Okay, again, can we start? Okay, let's go. So what is our topic is today is autoimmune hemolytic anemia. What do they call? AIHA. Very important for the examination purpose. Okay, now let's look at our definition. Destruction of RBC, right? Hemolysis, right? And then autoimmune mechanism, usually mediated by autoantibodies against erythrocyte surface antigens. Okay, that's our definition. Now let's look at some of the epidemiology. 1.77 cases per 100,000. Okay, and then 2/3 is warm autoimmune hemolytic anemia. So we'll come back to the types before, but remember 2/3 of them. So it's always very important pay close attention to autoimmune hemolytic A warm type. Okay, and majority of the warm is in the females. That's an important point. And the cold usually present after 50 years of age, and then you got paroxysmal cold hemoglobinuria mainly in the children, also noted. Okay, now the next thing we're going to look at the types. There's so many different types we need to know. Okay, so we need to know there's warm. Everybody knows that. Everybody knows about warm and the cold. Those are the main type. Okay, remember warm is in females, most of them, but 2/3 is warm. Remember that. Okay, warm, you got cold, and then you got secondary cold, and you got paroxysmal cold, and a mixed. Okay, this is actually, when you talk about warm and cold, you can say agglutinin disease. Okay, but when you come up to the secondary, you can say pretty much it's an agglutinin syndrome. I would say secondary cold agglutinin syndrome. Okay, just remember that. Now let's look at some of the difference. Mainly IgG in the warm, okay, antibodies, and IgM or IgG. In the paroxysmal cold, you got IgG, and in the mixed, you got IgG plus IgM. In some rare cases, even though I said IgG over here, IgM can also be in some rare cases. You can have that also. Just remember that. Okay, now in the warm, mainly the extravascular in the spleen, that's the main thing usually happen, but sometimes also in the liver also. Okay, in the cold, it could be extra or intravascular, but mainly in the liver. And then secondary cold agglutinin syndrome, you can have extra and intravascular hemolysis, that's in the liver mainly. And then when you talk about paroxysmal cold, it's mainly intravascular, and this one in the mix is not clearly established, whether it's intravascular or extravascular. Okay, now we're going to talk about, now the next thing is we have to do is we can do this Coombs test, which is called a direct antiglobulin test. When you do that, this is mainly IgG positive, and this one cold is like you have to think about C3d positive mainly, and secondary cold agglutinin syndrome, you can have C3d positive, and the paroxysmal cold, you can have C3d positive, and this in the mixed, you can have IgG plus C3d positive. It's good to know those criteria right here. Now, if you look at it, warm, idiopathic, cold, you can have lymphoproliferative. That's why we do in the cold. You always check for like a bone marrow. And then a secondary cold agglutinin syndrome, we talk about secondary causes. Okay, and then you got paroxysmal cold. You talk about mainly when you talk about the paroxysmal cold hemoglobinuria. Remember, in children, usually they get after like a viral disease. In the adult, you can usually they're present with like syphilis and then hematologic malignancy. Okay, so remember, make sure you read that. Now, the last thing we need to know the antigens involved, because remember we talked about, if we cannot remember anything about this, Always remember about the warm and cold. That's you need to know. And then we cannot remember both. Remember warm, because the majority, 2/3 is like warm autoimmune hemolytic anemia. Now let's look at the antigen also. In the warm, you got RH antigen, and in the cold is I antigen. Remember that. Okay? Everybody got that? It's a little bit complicated, but just kind of remind to go through one more time. Now, let's look at the clinical features. What will be some of the clinical features in the warm? Okay, usually you can have anemia. Everybody know that. There is like hemolytic anemia. It's usually gradual onset. You can have splenomegaly. You can have like hepatomegaly. Okay, and then you can also have like thrombosis also. Remember that. Okay, but when you talk about cold, it's kind of like an episodic. It doesn't have the gradual onset. Okay, you can have painful cyanosis. You can have livedo reticularis. You can have Raynaud's phenomena, you can have skin ulcers, and you can also have hepatosplenomegaly in that group. Okay, so everybody got this picture right here. Now, let's look at the pathophysiology, also very, very important. Okay, so we're going to start with the warm autoimmune hemolytic anemia, and then we're going to look at the pathophysiology. Okay, so what do we have here? Well, if we talk about warm, which antibody is in warm? IgG. So what do we have? IgG up here on your RBC, okay, and then that goes to the spleen, and then you got macrophages trying to attack this IgG receptor, and with the RBC, what happens? You can have hemolysis, and you can have like spherocyte formation. So you will get peripheral smear spherocytes. Okay, that's only in warm. Remember, if you look at the peripheral smear spherocytes, only in warm autoimmune hemolytic anemia. Okay, you know, also what happens is like after they attach to the RBC, they also activate the complement. Okay, C3, you got C3b, and the Kupffer cells in the liver start attacking this and then form the hemolysis also. Okay, very important to know that. So everybody know this warm autoimmune hemolytic anemia. Remember the peripheral smear. What will be the finding peripheral smear? Like spherocytes. Okay, are we going to have spherocytes in the cold autoimmune hemolytic anemia? Not really. Okay, so everybody got that. Now, let's look at the cold autoimmune hemolytic anemia. What happens? Somebody tell me which antibody is in mainly? IgM, right? You got IgM antibody. You activate what? Complement right here, okay? And then C3b formation, and then Kupffer cells trying to attack, and then you can hemolysis. Okay, that's the main thing. Now, it also activates the C5, C5-9b, and the MAC complex, and then that also get hemolysis happens in the RBC. Mainly, this is all happening in the liver. Remember that. Okay. Now, when you talk about there's another important type we need to know is something called Evans syndrome. When you have autoimmune hemolytic anemia and then ITP, you can have Evans syndrome. It's an examination, very favorite question. Okay, remember this Evans syndrome. Everybody got that? Autoimmune hemolytic anemia plus ITP. Okay. Now, let's look at some more classification. When you talk about hemolytic anemia, warm, you can classify them into primary. Primary is pretty much idiopathic. Nobody knows what else going on, right? And then secondary is mainly SLE, CLL, drugs, and alpha-methyl dopa, ceftriaxone, penicillin. The drugs can cause it, okay? So you need to classify them into primary and secondary. It's very important. Everybody got that? Okay, now then you have to talk about the cold autoimmune hemolytic. Again, you got a definition also. You can divide primary, right? We don't know the cause, like idiopathic, right? Everybody got that? And then what is the secondary? CLL, infections, EBV, mycoplasma, and HIV. Always remember mycoplasma. Somebody is going to write a question about mycoplasma. Okay, mycoplasma causing immune hemolysis is another examination question. Very, very important to know. So it's good to know this classification. Now let's look at our investigation, what need to be done. Of course, you check your what? Hemoglobin, right? And you check your hematocrit. There's both going to be low. What happens to MCV?
It's normal.
MCV is going to be normal. Very good. Okay. Now let's look at hemolytic picture. What does somebody tell me? Like, what are the common hemolytic markers we'll see?
Hemoglobin, hematocrit.
Hematocrit decrease.
Yes, hematocrit decrease.
Okay.
LDH is increased.
LDH is increased.
Haptoglobin is decreased.
Haptoglobin decrease. What happened to the bilirubin? What type of bilirubin?
Unconjugate bilirubin.
Unconjugate bilirubin. Everybody know that kind of picture, okay? And reticulocyte count increases, right? Now, you look at the peripheral smear, we already said it's only in the warm. Okay, don't forget that. That's another examination question, my friends. Okay, now then you do what is called Coombs test or direct antiglobulin test. That's actually the Coombs test. Okay, very, very important. You need to know that. So, what do? First, you got an IgG positive, C3d negative, IgM negative, diagnosis done. Okay, you got warm autoimmune hemolytic anemia. There's no further you have to do, right? So something you still have to do, but you know the diagnosis, you give the diagnosis, warm autoimmune hemolytic anemia, okay? Then, once you give the diagnosis of warm autoimmune hemolytic anemia, you still have to think about what the secondary causes, right? Remember, warm, you got primary and secondary, so a lot of things you still have to do. Your investigation not finished there, okay? So what you do is check the serological markers of autoimmune. So somebody tell me what is this when I talk about right here?
The
What is
second
that?
one, SLE.
SLE. Is it an autoimmune disease?
Yes.
Okay, so what do you do up here? Check for autoimmune, then you viral titers, you do a whole body CT scan you can do, flow cytometry because you're trying to look at the CLL and the serum protein electrophoresis, quantification of immunoglobulin. These are investigation you still have to do. Don't forget to do that, okay? Remember that. Let's say you do the Coombs test and IgG positive, C3d positive or negative, IgM positive or negative, or you got IgG positive or negative and C3d positive, okay? IgM positive or negative, then you have to go and do the cold agglutinin titer. Okay, and some number you have to know. What is the number, magic number you have to know?
64.
64, okay. If it is less than 64, it could be warm antibody. Warm autoimmune hemolytic anemia. Okay, you can give the definition and then you still have to do those markers right here. Okay, now, if it is greater than 64, you can say it's a cold autoimmune hemolytic anemia. Okay, and the next step is you rule out any underlying causes. Again, because we talk about the primary and secondary, right? Everybody got that? And then, if there's no underlying disease, you can say it's cold agglutinin disease. Okay, if there's an underlying disease, you can say cold agglutinin syndrome. Okay, now when we talk about once we know this is cold agglutinin disease, what are the things you have to do? You still have to do some more investigation. You do a bone marrow, okay, and then what else? You have to do electrophoresis, right? We talk about all the CLL and those kind of things. You still need to do investigation. So a lot of investigation even after your diagnosis, you found out IgM or IgG or warm or cold, you still have some more investigation. Don't forget to do that. Investigation doesn't stop there. Okay, here, if it is a warm, you still do the autoimmune workup, whole body scan, you do flow cytometry, serum electrophoresis, right? And quantification of what? Immunoglobulin. Got it? Okay. Now, let's talk about all this. Now we got it. Now we just look at the treatment. Again, there's a big treatment difference. Warm. Let's go to warm. Steroid has a role in it. The cold, do we use steroids? No. Okay? Always remember that. So, in the cold, we don't use steroids. Okay? And then you can have rituximab and splenectomies in the warm. In the cold, avoid the cold temperature. Rituximab can be used. There's another new drug called bendamustine. Remember that, bendamustine. Okay? The board question, some of the question is going to be about this. It's one of the new drugs. Now, you have to be careful about transfusion, okay? Of course, if the transfusion, you think hemoglobin is like less than 7 or some, we'll transfuse, right? In the warm, you have to be very careful. It's incomparability is extremely high because of this antigen and all those kind of things, right? So, transfusion, but if there's an emergency, even if it's not incomparable, you go and transfuse, okay? In the other, when you look about the cold, there's no incomparability problem, but make sure use blood warmer because you want the temperature around like 37 degrees centigrade. Everybody got that? Okay? All right, now I'm just going to stand back and I want everybody to look at this board. That's why we just wrote on this beautiful picture everywhere. Can everybody see this picture right here? Just kind of go through really fast one more time. to cover all of this. Okay, definition is pretty much simple. We now talk about it, right? We know 2/3 is in the warm autoimmune hemolytic anemia female. So if I'm writing a question, I probably write about female having hemolysis autoimmune hemolytic anemia. Got it? Okay, then we talk about this this types. You got warm and cold, secondary cold, paroxysmal cold, and mixed. And then we talk about Rh antigen positive in IG in the warm, and I antigen positive in the cold. Okay, remember that. It's very, very important. And then in the cold also you have lymphoproliferative disorder, bone marrow. That's why in the cold we do what? Bone marrow investigation and okay, remember that. And clinical features, pretty much anemia symptoms, thrombosis, and the cold you can have like Raynaud's phenomena, skin ulcers, and all of those kind of things. Okay. Now we come up to the pathophysiology. Very important. You got what happens. You got in the warm. What is it like? Warm, you have this IgG receptor attached to the RBC. Goes to where? The macrophages. Happening in the spleen, right? They get eaten up by macrophages. Then you can like spherocytes and the hemolysis and the periprosmial. What do you get? Spherocytosis. Okay, and then you also activate the complex. What? Complement, not say complex. Complement, and then liver. You got Kupffer cells start eating this up. Hemolysis happens. Okay, so periprosmial or spherocytes only in the warm autoimmune hemolytic anemia. Now let's go to the cold autoimmune hemolytic anemia. What is it? You got IgM receptor attached to the RBC, and then you got activate the complement right here, C3b, hemolysis, and then also activate the MAC complex, and you get hemolysis. Okay? Don't forget the Evans syndrome. Somebody tell me, what is Evans syndrome really loud? What is it?
Autoimmune hemolytic anemia plus
ITP. Definitely, that's like, it's an examination question, always you can expect, okay? Remember that. And then you got warm and primary and secondary. Primary, we don't know the cause. Secondary, you got SLE, CLE, that's another board question right there. And the cold, you got primary and the secondary. Always remember what the role of mycoplasma antigen causes, because they can write another examination question. Coming to the treatment, periprosmial only spherocytes again, warm autoimmune hemolytic anemia. Make sure you do this algorithm right here. And even if you diagnose after warm autoimmune hemolytic anemia, still have to do some investigations, okay? Because rule out the other causes. Now, we'll check cold agglutinin titers on this side. When it's cold, you got less than 64, it could be still warm. If it is greater, if it's greater than 64, it is cold. In the treatment, the other examination question is always going to be about steroid, okay? Steroid is only in what? In warm. In the cold, we don't use steroids. Remember that, okay? And now we talk about rituximab, you can do in both. And there's bendamustine, where to use in cold. Remember that, okay? Now, when you talk about the transfusion, always like when you talk about the transfusion, is incomparability is very common in the warm, but in emergencies, don't care about the incomparability, just go and transfuse. Otherwise, the patient is going to die, okay? But in the other, when you give transfusion in the other places, you make sure you warm up to 37 degrees centigrade, okay? Thank you so much for everyone watching. It's a great topic. Make sure you review it again. I can see at least so many questions can come from this. Thank you for joining us, and please subscribe to our channel, because it takes a lot of time and effort to make a presentation like that. Greatly appreciate it. Have a blessed day.